So really the biggest benefit of having that advanced practice provider in the transport team is being able to put everything together. And most importantly, as we were talking before about the protocols and being able to ask the why, that person is able to have the legal autonomy to step outside of those protocols at a moment's notice and really individualize the care for that patient.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement because we all know emergency nurses have the best stories. Now, here's your host, Kevin McFarland.
Hey everybody, Kevin McFarland here from the Art of Emergency Nursing, and welcome back to the podcast. I say welcome back, but this might be your first time here at the podcast. If so, welcome. I'm glad to have you here. My name's Kevin McFarland. I'm an emergency nurse from Texas, and this is a podcast where I interview fascinating emergency nurses from all over the world. This podcast is about all things emergency nursing. We have over 100 episodes for you to check out on my website or your podcast player of choice. You can also listen to episodes on YouTube. We have the audio-only episodes on YouTube. Definitely subscribe to my channel so that you get the updates. If you are not new here, then welcome back to the podcast. I'm glad you're here. Don't forget to leave a rating and review if you're a big fan of the podcast. That's a great way to help emergency nurses like you find a podcast like this. In today's episode, I have a podcast with Jake Miller, and he shares his journey from EMS to nurse educator to nurse practitioner. He has a great story and some cool and unique things that he does with his advanced practice degree. Jake was recently inducted as a fellow in the Academy of Emergency Nursing, and I myself know exactly what an honor that is, so welcome to the Academy, Jake. So sit back, relax, and enjoy this episode with my friend, Jake Miller.
So my name is Jake Miller. Right now, I am the clinical educator for a critical care transport team in Cincinnati, Ohio. But most of my background was in the fire and EMS service. So that was kind of my first real job out of high school, and then quickly went into nursing. That was kind of my original plan was actually my original plan was to go into medicine. And then I kind of saw what the med school pathway looked like and quickly chose to actually kind of go over into nursing instead. I didn't have a lot of financial resources when I was a kid, so it wasn't, we weren't poor, but we also weren't very wealthy. So looking at just making some fiscally responsible decisions for my future self and looking at, going to school for 4 years undergrad, 4 years of med school, 3, 4, 5, however many years of residency, versus going to a local, small community college for 2 years of nursing and then making a decent salary. I sort of chose the latter of those. But really ever since then, I've been involved in emergency nursing in some way, shape, or form. So my initial kind of nursing career was in the emergency department at Level 1 Trauma Center in Western New York State. And then after doing that for a little while, went to a community hospital because they had a flight program, which I felt was a great way to blend my emergency nursing background with my EMS background, and quickly learned that apparently flight nursing and emergency nursing are not exactly synonymous. Apparently, who knew? There's a lot of very sick, very critically unwell patients that are transferred by critical care transport. I guess the name is kind of right in there. It gives the tell away. But I quickly learned, sort of that Dunning-Kruger effect. You think you know what you know, and then you realize that you have no idea all the things that you don't know. And that was really what drove me to continue to pursue my professional growth, my personal growth. And that was ultimately what ended up leading me into going into my advanced practice studies and really looking for the way that I could continue to learn all the things that I don't know and continue to figure out how to practice to the best that I possibly can. And then with that, I learned that apparently I'm also reasonably good at presenting this information to other people, whether that's informally, just on shift, or whether that's in a formal setting, like through the conference venue or, teaching review courses or those types of things. And that's sort of what ultimately led me into my kind of side gig where I do present at a lot of national conferences. I do, obviously my current full-time job is as the clinical educator for the transport team. So that's really what led me to where I am now in, not only do I want myself to be the best that I can be, but I want everybody else to be the best that they can be as well. Because, some of it is selfish, it might be me, it might be my family that needs those people to
Amen.
help them. But
Amen.
also it's because I think that giving that gift to other people to help them understand, I think coming from the EMS background, a lot of us have that, these are your protocols, you follow the protocols, right? And in the ER, it's very easy to be taken away by, these are the provider orders, you follow the orders exactly, and you don't question them. But as any good, experienced, seasoned paramedic or nurse knows, sometimes you have to say, wait a minute, is this really the right thing to do? And, I want people to have that power to ask the question. I'm not asking you to pretend that you're a board certified emergency physician, but I think that sometimes we need to understand why we're doing things. We need to understand the why behind it, because that's when you understand, wait a minute, this might not actually be the right thing to do for this patient in this exact scenario.
I say that all the time. I tell people, blindly following rules or blindly following protocols isn't going to get you very far. Like you got to know. Like I spoke to a new grad nurse who is like, well, if I could just memorize these protocols. I'm like, don't memorize the protocols. Like I mean, you got to know the protocols, but know the reasoning, know why are they asking you for this or for that, and then it all makes sense. You don't want to just kind of blindly memorize this, just like it's not a cookbook, right?
Exactly.
So you start doing the education thing, and then start doing it with flight as well.
Yeah. So I guess actually we can back up a little bit too. So right now I'm the clinical educator for the flight program, but prior to that, as I mentioned, I had gone to advanced practice school. So I'm board certified as both a nurse practitioner and clinical nurse specialist. And I was working actually as a flight nurse practitioner for a number of years. So my first ever my first ever nurse practitioner position was as a flight nurse practitioner with the Cleveland Clinic's critical care team up in obviously Cleveland, Ohio. And that really opened my eyes to the possibilities of not only how advanced transport medicine has become, but also how advanced the knowledge and skills and performance abilities of the transport team really can be, and what the utility of using an advanced practice provider in that environment, all the benefits that can bring. And, a lot of people, when I talk about having a nurse practitioner or a PA or a physician on the aircraft, they immediately go to all the technical things that can be done, right? Oh, you can do this procedure or you can do that procedure. And really that's not, in my opinion, where the value of that person shines. And I think part of that is because in many states, now obviously, the usual disclaimer, scope of practice for any discipline. I don't care whether you're a nurse, a paramedic, an RT, whatever your discipline is, your scope of practice is dictated by your state. So, state A, you may be able to do this thing, and state B, you may not. So,
Yep.
so there's always that grain of salt. But really, when you look at it, a lot of the technical skills are limited kind of falsely by the institution, by your employer. In the state of Ohio, registered nurses are allowed to place peripheral arterial lines. They're allowed to place, actually, there's a bit of opinion statement by the Board of Nursing that a registered nurse with a proper order and training is able to place an IJ central line. So there's really the fact that nurses aren't doing that in the hospital. It doesn't mean that they're not allowed to. It just means that that institution has decided that that is not something they're going to allow their RNs to do. So really the benefit of having those advanced practice providers in the transport setting, it's not the procedures that they're doing. And likewise, it's not the knowledge. So obviously, yes, as an advanced practice provider, you do go to graduate school and gain additional knowledge in, the 3 Ps, pharmacology, physical assessment, and pathophysiology. There's also no scope of practice on that. If someone who is a basic EMT wants to nerd out on YouTube videos now and effectively take free open access med school, they're not going to come away with a medical degree, but they can get that level of knowledge to be equivalent to a advanced practice provider, a physician, whatever that level of knowledge is. Sure, they may not have the clinical experience because they're not doing the clinical rotations, but they can get that knowledge and understand the pathophysiology behind what's going on. And as I was talking about before, understand that why. So really the biggest benefit of having that advanced practice provider in the transport team is being able to put everything together. And most importantly, as we were talking before about the protocols and being able to ask the why, that person is able to have the legal autonomy to step outside of those protocols at a moment's notice and really individualize the care for that patient. And it's not to say that nurses and medics and other disciplines, RTs or whoever is in that transport setting isn't doing that from time to time. The problem is you kind of walk that very gray area medical legally of, well, your protocol says to do this, but you did that. And you may be able to justify it and rationalize it, but if you don't have the legal authority to do that, I think that's where a lot of folks have the potential to get into trouble. And sometimes it's a case of and justify the means. If you did the right thing for the patient and no bad happened, nobody's really going to question it. But if you did what you thought was the right thing for the patient, and even if it technically was the right thing for the patient, but a bad outcome happened, if you didn't have the legal authority to deviate from your standard orders, there's going to be a problem.
Mhm.
And we know that in the emergency department, we know that in EMS. I mean, those are things that we have, those orders, those protocols are written for a reason. And it's not to
Absolutely.
say, as we talked about before, it's not to say you blindly follow them. But if you have to step outside of them, or if you have to question them, you, without prescriptive authority, you have to question them to the person who promulgated those orders for you, whether in the emergency department, it's the FAEN physician, whether in the EMS setting, it's online medical direction. You still have to question those and get the approval to deviate from them. Well, the problem is at 3,500 feet over God only knows where in the Midwest, with no radio communications and no cell communications. How do you do that?
Yeah.
And I think that's where a lot of the benefit of having that advanced practice provider can really shine in the critical care setting. And then you have the EMS opportunities as well, where we see these great programs that are incorporating advanced practice providers into their EMS systems. I mean, one of the best ones that I can think of is, down in Texas, they've got Austin Travis County, where they're paramedic practitioners, which is just the name they give to it, because really these are folks that are actually largely PAs that also have an EMS background. I think many, if not all of them, are also paramedics, thus the term. But they're going out in the streets and they're, riding on the ambulances or riding on the chase cars, and they're meeting people where they are and being able to properly treat them, dispo them. There may be some element of case management, arranging follow-up. There may be some, prescription that needs to be written for a very minor care issue. But as a result, your EMS crews are getting returned to the street sooner, be able to deal with emergency runs. Your emergency departments are not getting backlogged with these patients that don't need to be in the emergency department.
It makes
Maybe
a
they need
ton of
urgent care.
sense.
Absolutely. These are patients that they need help. And I'm not trying to minimize that at all. I mean, when someone calls 911, it's their emergency, and you really need to put some value in that. They called because they need help. They have a
Absolutely.
problem that they need solved, but they may not need to be in the emergency department, right? So that's where I think the other part where this can help on the EMS front line is getting those practitioners out into the streets and being able to decompress the otherwise overwhelmed emergency system that plagues the entire nation, in fact, the entire world.
Yeah.
I mean, we think that this
Absolutely.
is boarding and all that stuff is terrible in the United States, but I mean, they're still having the same problems in the UK and Australia and
Yeah.
all of these countries
Yeah.
all over the world.
Yeah. One of the things I find is no matter where you go in the world, like a lot of the same problems.
Oh, absolutely.
So,
I mean, there's some stuff that we do to ourselves, but I think there's a lot of things that are across the entire country. I mean, some of the financial structures that we impose in the United States is different than other places that have different healthcare payers.
yeah,
But at the end of the day, I think a lot of the operational things are still,
yeah,
it doesn't matter who's paying for the care. The point is people are showing up to get the care. Right.
yeah, exactly. Exactly. So, so you started your nursing journey as a 2-year degree in ADN, did you say?
Yeah. So I started as a 2 year. And I think a lot of the time when I reflect back on this, reality was that was just the most cost effective way to do it. When
Yeah.
I was, I at least had the insight as a little whippersnapper to be able to think and plan out my career and weigh the different options. So when I looked at nursing, I looked at, there's a 2 year degree, 4 year degree, and the difference between the two of those is 2 extra years of debt. That was pretty much the difference at the time. I'm not sure if that's still holds true today. I think there's a lot of hospitals, especially with magnet recognition and stuff, that are still kind of preferentially hiring the BSN prepared.
Yep.
But when I went to nursing school, I think it was 2004 when I graduated high school. So when I went to school, when I went to nursing school, first of all, there were no like free entry exams or anything like that. It was really not that competitive to get in. It was like, oh, hey, I want to go to nursing school. They're like, okay, you start in August. So that was the admissions process.
I remember as a new nurse, I remember as a new nurse, I was in my community, the nursing program had a wait, and it was like about a year wait for the nursing program, depending on when you applied. And I remember going to another community and looking into moving there and looking into possibly going to nursing school there. And I remember asking, I was like, well, how long's the wait for nursing to get into the nursing program? Like, what wait? And if you get the prereqs done, you're in. Like, we'll get you started. And I was like, wow, like back home, there was like a 1 year, up to 1 year wait. And luckily it wasn't that much when I got there, but by the time I was ready, but I was like, and they were like, no, there's not a wait. We need nurses. Why would we wait? And I'm like, just
Yeah.
blown
I
away.
think And I think some of that too is just like the variability. I mean, like you said, from place to place, it's probably going to be variable. But
Yeah.
yeah, so I looked at that, and either program I could have gotten into right away. The big difference was at the end of the 2 years, I could get a license and start working, and then continue my educational journey, or I would have to wait the 4 years, rack up an additional 2 years worth of debt, and then it could start working. So I just chose to do the 2 year. But after I was working for probably about, I think 3 years in a clinical setting, I did go back and finish my bachelor's degree. I saw the opportunity to
Yeah.
do that. Again, this was kind of in the mid 2000s when,
Nice.
some schools started recognizing that there are nurses that want to get their bachelor's degree. So fortunately, one of the colleges in my area, they had I think it was like a 50% tuition reduction for the RN and BSN completion.
It's
So I'm
amazing.
like, oh, I'm going to capitalize on that too. You know,
That's awesome. That makes it a lot easier to go. Now,
Absolutely.
did you do the CNS first or did you do the nurse practitioner first?
So I actually the program that I went to was a blended program. So we actually did concurrently the NP and the CNS
Interesting.
education.
Now,
And when you look at it, there's actually a lot of similarities between the two roles. They do diverge at some places, but really the core group of, for example, the three Ps, right? The pharmacology, physical exam, physical assessment, and pathophysiology. When you look at those, I mean, that's core amongst all APRN roles, whether you're
yep.
CNP, CNS, midwife, or a nurse anesthetist. Everybody has to do those. In fact, in our physical exam class, in our pharmacology class, in our pathophysiology class, we had folks that were in the CRNA program. We had people that were in the midwife program. So, it makes sense to blend some of those things together. And then similarly with the CNS scope of practice, now that is something that is far more widely variable from state to state to state.
Yep.
NP kind of, but is largely, I think everybody knows what an NP is from
Yeah.
state to state. The
Yeah.
CNS tends to be a lot more of a wild card.
Absolutely.
And
And
so,
for the audience, tell them a little bit about that CNS role. So I think that's something
yeah.
that not a lot of people know a whole lot about.
Absolutely. So, I mean, we know what a nurse practitioner is. I think everybody kind of conceptualizes that. That's an advanced practice nurse. You can go to, they see you as an individual. They can diagnose and prescribe treatments for whatever condition you may have. And of course, there's different flavors of nurse practitioner, right? There's family practice, there's acute care, emergency, all that sort of stuff. But the CNS is really looked at as, if you truly embody the role of that as designed at its highest level, it is an advanced practice nurse. So this is someone who should have prescriptive authority, who should have the ability to function as a licensed independent practitioner, very similar to how a midwife and an anesthetist or a nurse practitioner functions. And the big difference between the nurse practitioner and the clinical nurse specialist, the best way to describe it, in my opinion, is that the nurse practitioner looks at the individual, the CNS looks at communities or groups or cohorts of individuals. So whereas a nurse practitioner is taking care of one person, the CNS is kind of trained to look at that population as a whole. So when you're looking at emergency patients, you're looking at the broader group of patients that are coming into the emergency department, or the broader group of people that are coming to the urgent care setting, or, if you're a CNS on a neurosurgical ward, you're looking at the broader populations of NSICU patients. And I think that's the biggest difference. Now, certainly within that population, that CNS in some states are able to, treat one patient at a time, just like an NP could. But the value is that the CNS really looks at the broader population. And the CNS practice model is termed like the three spheres of influence. So within those three spheres of influence, those are the individual patient and communities is one sphere of influence, but then also nursing and nursing practice, and then organizations and systems. So those are your three spheres. And that's where a CNS is trained to intervene on all of those. And that's why I think a lot of times, unfortunately, the problem with that is you look at that nursing and nursing practice, and a lot of hospitals will look at that and say, oh, so you're an educator.
Yeah.
And that's where, sadly, a lot of CNSs end up into that education role. And I'm not in the education role right now because I'm a CNS. I'm in the education role right now because, very briefly, I had a decision I had to make. Did I want to be a nurse practitioner and not work in transport anymore? Or did I want to work in transport somewhere and not necessarily be a nurse practitioner? Because we had some financial challenges at my institution after the whole COVID fallout, as many hospital systems across the country did.
Absolutely.
So I chose education kind of because that was my choice, not because, oh, you're a CNS, you can be an educator. But unfortunately, a lot of CNSs, that's what they find. They have a job that is posted as clinical nurse specialist, and they get in there, and really it's just staff education.
Yeah.
But the CNS is trained to do so much more, to look at, especially CNSs that have a doctoral degree. You're looking at that evidence translation. You're looking at, improving organizations, systems leadership. Looking at not only your department protocols, but also hospital-wide policies, community-wide policies. So I think that that's really where the value of the CNS shines. And unfortunately, I think that there are many systems that do a great job implementing CNSs into their system. But I think there's a lot that just don't really understand at the leadership level what a CNS is. And as a result, a lot of CNSs are sadly underutilized.
Yeah, absolutely. So. And how did you like doing the nurse practitioner role and for the flight team? How was that? What was that like?
I really enjoyed it because I think that being a nurse practitioner in the clinical care transport, the EMS setting, as I mentioned before, it really is a matter of doing what's right for the patient. You have your protocols, you have your guidelines, you have whatever you want to call them, but you have the ability to say, for this patient, this is probably not the right thing for whatever reason, and this is what we're going to do instead.
Yeah.
And you're able to really individualize that care. And I think it really blends the best of what emergency nursing is, what paramedicine and EMS is, and what advanced practice training and education and authority allows you to do. and you put all of those into a big melting pot, and you come out with this transport nurse practitioner. And I think that that's really the best way to provide care for these patients. And the way that I kind of try to explain it to some folks that are like, well, what's wrong with like nurses and flight nurses, flight medics, and those folks is there's nothing wrong with them. But just like how you would never expect to go into the emergency department as a patient and be seen by a nurse working off of protocols and never see an NP, a PA, a physician,
Yeah.
you go into you get admitted into the ICU. I mean, like I mentioned before, some of these patients that we're flying they're sick ICU patients. And you would never expect to go into the ICU and just have like, a nurse go into the computer and pull up, oh, you've got cardiogenic shock. I'm going to pull up the protocol and we're just going to start treating you. And, you just maybe see a physician tomorrow.
Yeah.
Like we wouldn't anticipate that happening, yet we say that, oh, it's okay for that to happen in the dynamic environment of the transport world, where these patients now are in a different environment, a smaller environment, a resource limited environment, with the added stressors of, temperature, vibration, noise, and we're just going to run off protocols to manage them. I think in many, many patients, that's probably fine. And especially, like I said, there's no scope of practice on education. So I think a lot of our clinicians that are out there that are doing this, our EMTs, our paramedics, our nurses, respiratory therapists, I think a lot of them are very well educated. And as a result, we have some excellent outcomes in the transport setting. But I think that occasionally you run into that issue where you need to modify the game plan and you need to do it now.
Yeah.
Or you need to recognize that you are going to need to do that in the very near future, and you have to start coming up with your plans A, B, C, D. And I think that's where that advanced practice provider shines, because they can just say, okay, this isn't working. This is what we're going to do now. It's not scripted, not a protocol, but trust me, this is what we need to do.
Yeah. Absolutely. What an exciting role. What a cool role to be able to have and fill.
Absolutely, yeah. And I've been, especially when I was at Cleveland Clinic, so not only did we do ground and rotor in kind of the local area, but the helicopters that we had the Sikorsky S-76s, and those have a pretty decent range on them.
Yeah.
So we would do rotor trips, as far as, 150, 200 miles in any one direction. So I literally have been all over the entire state of Ohio by rotor, up to parts of Michigan, New York, which actually was very interesting because I grew up in like the Buffalo area. And when I was living in Cleveland, occasionally, I'd drive home to visit family and whatever. And it almost seemed like it never failed that I would be in Buffalo visiting my family, drive back to Cleveland, and my next shift on the aircraft, we'd be flying out to Buffalo. Shift. It's just here.
Okay, it's just here.
Yeah, but not only did we have the rotor in the ground, we also had fixed wing. So we would do jet transfers both domestically and internationally. So, we would bring patients from all across the country, but also I was able to go down to the Dominican Republic for a patient, I've been out to Italy, out to Romania.
That's awesome.
So very, 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 very cool. Unfortunately, when I moved from Cleveland down to Cincinnati, the Cincinnati team doesn't have fixed wings. So I kind of had to, now if I want to travel, I actually have to pay for it myself, which is annoying. But also when I want to go to Italy, it's like, talking to someone like, oh, you were in Italy last week. Oh yeah. How long were you there? 12 hours. And you just kind of get like these sideways head looking like, what? Like, hey, I was for work. So now I can actually go and spend some time when I want to travel. But I still think it was really cool to be able to do that and just visit all these places you would never think to go to, for the purpose of bringing that patient back to the States to get, either the ongoing care they needed, or maybe in some cases like the higher level of care that just couldn't be provided in that setting.
Okay.
Yeah.
But so, what advice could you give to somebody who is an ER nurse who's looking at getting into like the nurse practitioner role, wants to do that, not really sure what they want to do with it yet, but looking at that practitioner role down the road?
Yeah, so I think that there's a couple things to keep in mind. First of all, and part of this has nothing to do with their clinical background. So I think that the first thing you have to understand is, and this varies widely from state to state, but looking at your scope of practice and trying to figure out which flavor of nurse practitioner you want to be, right? So there's family nurse practitioners,
Yep.
acute care nurse practitioners, and the way the system currently is designed, emergency nurse practitioners is not it's not a population of itself. It is a specialty certification within another population.
Right.
So very similar to how the CEN is not a nursing degree, it is a specialty of your RN license. And the reason I bring that up is because when you look at what a lot of state boards of nursing are starting to opine, they're starting to say that the emergency care setting is maybe not best suited by family nurse practitioners, depending on what you want to do within that setting.
Yeah.
And basically, when you look at the larger setting and you look at the LACE model, which is the licensure, accreditation, certification, and education for any advanced practice nurse, the population that you are treating, so whether you are family or acute care, that population doesn't matter where that population is. What
Yeah.
it really gets to is the needs of the patient, the acuity of the patient.
Mhm.
So if you're a family nurse practitioner, pretty much all boards of nursing say if you work in minor care, urgent care, you see your ESI 4s and 5s, that is totally appropriate for FNPs.
Absolutely.
Many states, however, have started to say if you are expecting to see the ESI like 3 highs and 2s and 1s, that is 100% outside of your scope of practice as an FNP.
Gotcha.
Now, again, your mileage may vary, and that's why you really need to do your homework to see where you intend to work and what setting you intend to practice in and what patient you intend to see. But some boards of nursing have flat out said, so for example, in Ohio, we used to actually have in my flight program that I'm currently working for, we did used to fly with nurse practitioners, and some of them used to be FNPs.
Yeah.
But the Ohio Board of Nursing came down and said, what you're doing and how you're licensed does not match.
Mm.
So you
That's too
have
bad.
2 years to get your acute care or get off the aircraft.
Wow.
And so as a result, all of our nurse practitioners were acute care certified. But the I don't think a lot of hospitals are looking at that. As I mentioned before, a lot of hospitals don't know the difference between an NP and a CNS, or a CNS and a nurse educator.
Yeah.
So a lot of these hospitals are not going to know the difference between an FNP, an ACNP, an AGACNP, PAGs, whatever all the alphabet soup is.
All
They're
the
just going to
alphabets.
say, yeah, you're a nurse practitioner. You are represented that you are qualified to work in the emergency department. Therefore, you can. The issue is going to come down where if you are not qualified for your state board of nursing rules and something bad happens, you're kind of on the hook for that, right?
Yep.
So I think that's
Absolutely.
one of the first things that that people need to understand is you as a nurse practitioner or any other advanced practice nurse are responsible, just like as an RN, you are responsible to know your legal scope of practice and to work within it.
Yep.
So that's the first thing that I would say. The second thing that I would say is get some experience. Don't try to speed run the game. The unfortunate point about advanced practice nursing education today is that it is still designed for the well-experienced nurse that wants to go on to become an advanced practice provider in their current area of specialty practice.
Correct. But
Not right. Right, but it's not designed. We have not, as a profession, we have not kept up with the fact that nurse is now a nurse with, if you're lucky, 6 months, a year of experience. We
Mhm.
see a lot of nurses that are going directly from nursing school into APRN education without even getting any clinical bedside practice outside of their RN clinicals, pre-licensure
it's
clinicals.
it's crazy.
And it's not, I'm not saying that that's a bad idea, but I'm saying that the system is not designed for that. The system is designed for those nurses to draw on their experience and their expertise. And I think I'm just going to go out there and say it that if you really want to do that, if you want to go from nursing school directly into an advanced practice field, go to PA because they are designed to take people from zero and give you all of that clinical acumen to
Yeah.
then become an advanced practice provider. And they have it structured in such a way that that is the model that they follow. It's longer
Yep.
schooling, but it needs to be, because you
Yeah.
need to go through all those different clerkships. You need to have all of that understanding that you're not going to get if you just came out of nursing school and are now going into an advanced practice field.
Absolutely.
So I think that that's probably the better model. People can hate me for that if they want to, but I really think that until our APRN education catches up to the fact that we need a much bigger and broader foundation, and we need to have the ability to build folks up with minimal experience now, I think that that's where that's one of the biggest struggle points of APRN education. I'm
Yeah.
not trying to dissuade people from becoming an advanced practice nurse. Like I said, I'm an APRN, but also the other thing you have to consider is that we still have those population silos. So I was talking before, this family versus acute care. So family
Yeah.
is really looked at in most states as primary care only. There's some states that, their opinion differs, and that's state rights. They're allowed to do that. So there are some places where you may be an FNP and you can lead a resuscitation or work in the ICU.
Yeah.
And if that is what your state allows, then that is totally fine. But you go to a different state and you try doing that, and
Yeah.
you may be
May not
working
be.
very much outside your scope of practice.
Absolutely.
So, you've got your FNP, your adult acute, peds acute, all these different things. Emergency, like I said, is a specialty certification. So the problem is you really have to understand what it is you want to do. There are some emergency programs out there that actually, as I mentioned, my background, I went to one program and I was prepared as an acute care NP and acute care CNS.
Yeah.
But there are some programs out there that will prepare you, for example, as a family nurse practitioner and acute care nurse practitioner.
Sure.
And that gives you kind of both of those specialties to be
Yeah.
able to work in an emergency department and have the expertise in both the low acuity and the high acuity management of those patients.
Absolutely.
So just do your homework in looking at, what preparation you're going to get out of that, and looking at how that matches with what you want your eventual career goals to be. And I would be remiss if I didn't do a shameless plug for actually a conference presentation that I'm going to do at Emergency Nursing 2024 in Vegas. Myself and Teresa Dodge are going to do a presentation on exactly this topic. It's
That's awesome.
called So You Want to Be an NP in the ED? Let's talk. And basically, we're going to bring up a lot of these different considerations that people should be considering when they want to go into an advanced practice role, and what that looks like, and how that differs, from state to state, and how that differs within, practice settings and clinical backgrounds and those types of things.
I'm sure that's going to be a very popular talk because there's a lot of people that are looking at getting their advanced practice, but I don't think they always know exactly like what the plan is to do with it.
Exactly.
So, but well, man, this has been very informative. I really appreciate you taking the time to do this. I don't want to take up too much more of your time, but I really appreciate you going through and answering some of these questions that I know some of my audience have.
Yeah, I appreciate the opportunity to come on here and kind of talk about my background and my experience, and most importantly, to be able to highlight that, there are, even though my program has kind of moved away from having nurse practitioners on our critical care transport team, there's still several that are actively using that practice model. And there's still several programs that are exploring whether or not that's something that they want to do. The unfortunate rule is that you still have to be able to, I don't want to say necessarily make a profit, but not operate in the red, right? So I think many of us are very interested in doing what we're doing, but at the end of the day, we also want to get fairly compensated for it. So the
Absolutely.
problem is, you look at at EMS as a whole, and critical care transport falls under EMS as far as CMS and insurance is concerned. And you basically get like one lump sum regardless of the level of care that's provided. So if you do that with two basic EMT, well, I guess that's a bad example because there's ALS versus BLS, but you do that with, an EMT and a paramedic, you're going to get the same exact reimbursement as you do with an EMT, a critical care nurse, and a nurse practitioner, or even, an EMT or a critical care paramedic driving the truck with a nurse practitioner or physician in the back. You're going to get the exact same reimbursement. Doesn't matter because you're providing.
That's too bad.
Yeah, this standard definition. So as much as I think a lot of programs want to explore this model, they also have to look at sort of the cost benefit analysis of that. And I fully understand that from the business model, but Just understand that this is an emerging practice model. There are several different organizations that are advocating for this, including the National Association of EMS Physicians. We actually have now, we were a task force. We turned into a committee. So we are a standing committee within NAEMSP looking at how
great.
to incorporate advanced practice providers into EMS care. The individual, so the American Academy of Emergency Nurse Practitioners has a special interest group just for EMS practitioners,
That's awesome.
EMS NPs. And SEMPA, the Society for Emergency Medicine Physician Associates, they also have an EMS group that works under them for their profession. So this is something that I think is really interesting to see where it's going to go in the next decade or two, and just for folks to understand that it's out there. It's very selective right now, very small groups that are doing it, but there's a lot of interest in there. And if someone is able to develop a really good business model to expand this, I think that's really what the industry needs to be able to more regularly use this practice model and to bring that level of care to all of our patients wherever they are.
Yeah, I think it has so much potential. So, well, very cool. Thank you so much for taking the time to do this with me. Really appreciate it.
Absolutely. Yeah. Thanks for having me on.
Take care. See you in a couple months.
Yeah.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.